live on Periscope. Can you just put your hand up if you've not been to a health chat before? Okay, fine. Well, the purpose of a health chat really is just to bring the big names in healthcare closer to the people who actually deliver the healthcare. And so we've had some fabulous guests, and none so fabulous as the guest we have tonight. But we are live on Periscope, which is a fantastic little app that works with Twitter, and it means we can broadcast live anywhere in the world, really. And am I okay? We're working. Okay, so all the everyone on Twitter and Periscope that's joined us, you're very welcome, and thank you very much, and welcome to Health Chat, the King's Fund. We can't, of course, have these fabulous evenings without our sponsors, Interserve and IMS Maxims, and we're enormously grateful to both of them for sponsoring this series of health chats. We weren't sure where we were going to go at the end of last year, whether we could keep going, but we have, and thank you very much to our sponsors. Thank you both very much. Why are you pointing at me, John?
Michael from IMS Maxims is going to say a couple of words.
Oh, is he? Oh, right. Come on then. Come on then. Yes, please come along. Yes, this is Michael from IMS Maxims who's going to say a few words. Unfortunately, it's cost him so much to sponsor us, he's had to sell his tie.
Whoever would dare follow Roy Lilley, I tell you. Well, my name, as you've probably heard, is Michael Thick. I'm the Chief Medical Officer for IMS Maxims, who's one of the sponsors this evening. And it's my very great pleasure to be able to introduce Cyril, who has been...
Our secret guest.
Our secret guest, apparently. Since we're paying for it, we can say so. Who's been a close colleague for many, many, many years. We started off with guys together in nephrology. He doing the pediatrics and I was doing surgery. I was a great deal more junior then, but he was very kind to me all the way through. And somehow our careers have intertwined and come across each other all the way through to right now. And from our point of view, the pleasure is that he completely understands the context of how clinicians are going to be deeply involved in the transformation of healthcare, and how the use of information systems is going to be important in that journey. And he has supported us right the way through the time that I was with Connecting for Health, which was difficult, as we both remember. So who knows what traps Roy is going to lead him into this evening, but I hope you enjoy. Thank you.
Thank you very much. Patrick, would you like to say a few words?
I don't want to get in the way of the main event.
Oh, that's okay, fine.
I do, please.
Ladies and gentlemen, please welcome our guest of honour this evening, Professor Cyril Chantler. Thank you very much. Are we all mic'd? Are we still? We got.
Yes, and I've turned it on.
Yeah, well done. Thank you very much. It comes to something when men of our age come to London and have to turn ourselves on. There you are. Well, you're welcome. What have you got there? A speech? What's that for?
It's my notes.
Well, you're going to give a speech?
Yes, probably.
No, I don't. I think you've got a fantastic career. I hardly really know where to start. So what we usually like to do is to start right at the beginning. I mean, why medicine?
I always wanted to be a doctor, and I'm not quite sure why, but from the age of 12...
Was your family a doctor?
No. I had very bad asthma as a child, that I do remember very well. And I can remember holding the bed stead, thinking I couldn't breathe and I was going to die. And there was no treatment for it at that time other than going to hospital and having an injection of adrenaline. So I got I was conscious of illness quite early on. I grew out of it, so it's not a problem now. But I've no idea, but I knew right from the age of 12 years onwards I was going to be a doctor.
All right. You went to medical school where?
Cambridge and then Guy's.
Yeah. Good time at Guy's?
Yes, well that's where, oh wonderful, yeah.
It was very different in those days.
Cambridge was fun, but I wasn't very excited by the medical course. It was all about science and nothing was about patients and caring. So, in fact, I even wondered whether I really wanted to be a doctor at that point. But the day I walked into Guy's was the first day of the rest of my life. It was just wonderful. And I became a paediatrician because the paediatricians seemed to me the most human doctors in the place. They were all terribly clever doctors, but they didn't seem to me the sort of doctors I thought I wanted to be, where the paediatricians seemed to me just the sort of person I would hope to be as a doctor. So that's why I became a paediatrician.
And then you specialised in nephrology, I think, didn't you?
Yes.
Was that, at what point did you get into nephrology?
Well, the kidney is much easier to understand than the brain, so that was quite a good start. I thought these things are just serendipitous, and serendipity is wonderful, because most medical advances involve serendipity. But I worked for, I was interested in kidney disease. There was a condition called nephritis. And the explanation of what caused nephritis seemed to me, I just could not understand it. It seemed complete nonsense. And then a man arrived from America, and he was the professor of medicine in Chicago. He was a South African who qualified from Guy's. Called Professor Kark, and he'd been the hooker in the Guy's rugby team. For those of you who don't understand rugby, the hooker is in the middle of the front row, and they all look the same. And if you're any doubt, just look at their ears. And he looked like a hooker. He was huge. And he had pioneered kidney biopsies. And for the first time, there seemed to be some rational sense in the description of the pathogenesis, the cause of nephrotic syndrome. So that got me very interested. And then I was taking my membership, and I needed 6 months before my next job. And the professor of medicine suggested I work for a wonderful man called Norman Veal. Now, Norman Veal had left school at 16. He worked in the meteorological office. He then worked as a technician in Rutherford's laboratory in Cambridge. Then at the outbreak of the Second World War, he was sent to Canada to work on the atom project. And afterwards, when he came back, he was working at Harwell, and he was called to the inquiry on the atom spies. And they said, Mr. Veal, he got an external BSc degree when he was in Canada with his scripts coming on convoy back to London to be, well, anyhow, they said, Mr. Veal, did you give any secrets to the enemy? And he said, no, he said, I did not give any secrets to the enemy. They said, thank you very much, Mr. Veal. He said, but before we go any further, you must understand, the only reason I didn't give any is I didn't know any. he said, if I'd known them, I would have certainly given them, because this was the only way he thought to save the world. So they thank you very much. But when he got back to Harwell, they weren't very impressed. So he was sent from Harwell to the Hammersmith Hospital, where he became the father of nuclear medicine. And he was an absolutely marvellous man. The first scientific paper I ever wrote, I gave it to Norman, who I was working for, and he took it home. And the next day, I met him and I said, so Norman, what did you think of the paper? Yes, he said, it's interesting. He said, somebody has to do some work on a scientific paper, Cyril. It's either the person who writes it or the person who reads it. He said, I think the convention is it's usually the person who writes it. So we were measuring kidney function using a new radioisotope method, which he sort of invented. And he mixed all this stuff up, really very dangerous radioactive chromium in this, what he called the hot lab. He used to smoke cigarettes, and he used to put them in a holder when he was in the hot lab, so he didn't contaminate himself. He put all this, and then he put them into some little vials, and he put them inside a domestic pressure cooker on a Bunsen burner, and they turned a rather nice colour, violet. Michael knows all this. And anyhow, after we'd done some tests on it and run it through some cephalopod columns and so forth, one day he got out a syringe, drew up 10 cc's and injected it into me. I said, well, hang on a bit. I said, shouldn't we inject it into an animal? He said, well, what sort of animal had you in mind? I said, dog, maybe? He said, I thought you wanted to measure kidney function in children. Inject it. So I did. And we measured his kidney function. And in return for that, he injected into me 9 times over the next 2 months. I was so radioactive, I didn't tell my wife. Anyhow, the kids are all right. But and that was the start of my research career. I was working for the MRC at the time because he was the head of the MRC radio nuclear medicine unit. So that's how I got involved in nephrology.
How interesting. And then what happened from there? Because you've made some interesting transitions, haven't you? You've gone from sort of pure applied medicine, clinical interfaces, into management, into running organisations. You ran here, didn't you, for a while? I think the King's Fund. Or?
Chairman don't run things.
Well, you know,
when I was
speaking as a former chairman.
Yeah. when I was chairman of the King's Fund, the chief executive who we appointed was Neil Dixon, and I had this idea, which I still have, by the way, that trustees should do more than just be trustees managing, the sort of money of the organisation. I said we should have trustees who function partly as non-execs. They have skills and experience which they can put at the disposal of the executive team. So I said to Neil, would that be all right? He said, Cyril, that would be fine, as long as you don't get into the sandpit and start playing with the toys. And he's quite right, you don't want the chairman to do that. So I was chairman of the King's Fund. You know, what happened was that I always wanted to be a paediatrician, but you had to train as an adult physician and pass your adult membership at that time before you became a children's doctor. So I did that. I was an adult registrar, and then I went to the Hammersmith as an neonatal house officer. Then I was a registrar. Then I did more work for the MRC. Then I was a senior registrar and did more work for the MRC. And then I was lucky enough to be appointed to Guy's in 1971. One of the things that worries me, and we may get onto it later, is I was very lucky because we organised our own career training. But I had 1 year as a senior registrar and 1 year as a middle grade registrar. And when they appointed me to Guy's, I wasn't actually trained sufficiently to be a paediatrician, say, in Brighton. But I was perfectly well trained enough to be at Guy's, because I was surrounded by Guy's by some very, very experienced people who had taught me. And I knew my limitations, and I constantly was asking them for advice. I did that for the rest of my clinical career, because nowadays you work in teams. It takes, in this country, 8 years of training to be a consultant paediatrician, and that's on top of 2 years as an SHA, so that's a total of 10. In Germany it takes 6 years from qualification. In France it takes 4 years of specialty training. And I think that's just too long, because you do not have time to do other things. You don't have time to take time out to research or to go and work abroad in Medicine Sans Frontières or whatever, because you're pursuing your training. And you train in things that you don't need to be trained in. We want this notion of just-in-time training, or laddering across when you've got experience in one speciality, which should be added to your experience when you go to another. And so it worries me that it takes so long, because I think it's unnecessary, and I think it is part of the problem in the current way we organise training in this country. And of course the converse of that is, in general practice, you don't get any paediatric training at all, which is wrong. Because they need 4 years, not 3 years.
When you think of the daily list of customers that a GP is likely to see, it's all about families, isn't it? And family practice, mums and their kids.
Yeah.
Yeah. So it is interesting. And we'll go back into cricket, because it is very interesting. But it dovetails neatly now into what we're all thinking about now, which is the junior doctors dispute. It seems to me it's a political dispute with the adjunct of Tory Central Office known as the Department of Health and the BMA, and everybody else is caught in the crossfire. How do you see it ending?
I don't know. I think it's desperately disappointing. Let me say that I don't think doctors should strike. I think that is not part of the professionalism of being a doctor.
You see, I think that as well. I on the telly the other day, I found it very hard to, as much as one might sympathise with the junior doctors, or perhaps even there are faults on both sides and there are pluses and minuses on both sides. I can't bring myself to support a doctor going on strike. Do you think that's, I don't know, a generation thing? Do you think
No,
the doctors see it
actually,
differently?
I resigned from the BMA in 2012 because they were supporting a strike. I actually phoned them up. No, they phoned me up after that. They said, do you know you've been a member now for 49 and a half years? Oh, I said, have I really? They said, yes, you go another 6 months. You get it free for the rest of your life. Very tempting. But I did actually resign. Now, having said that I don't think doctors should strike, I also have to say that I have a huge amount of sympathy with the junior doctors at the moment.
Do you understand the dispute? Because it's such a
No, I
mess.
don't. But
It's
I-
like a coral reef. It's just
Yeah,
grey.
I don't understand it tactically at that level, and you know I've been retired from clinical practice 15 years, but I think I have a view about it strategically. One of the things that's changed over my lifetime is medicine has become less professionalised. It's become more of almost a trade, a contract, where I was appointed, I say, in 1971, and I can't actually find my letter of appointment, which is a nuisance because what I'm about to say may just be wishful memory rather than actual fact. But as I say, I only had a letter, and the letter said something along the lines, well, I have to offer you the job, thank you very much. You will be required to attend to your duties for 37.5 hours a week, or whatever time it takes to fulfil them satisfactorily, which turned out to be over 80. Well, you know, that was all right. Maybe all right for me. It wasn't perhaps so good for my wife and my family. But, and I don't think you should work those hours now.
Were you around
today,
in the
but-
1975 strike? You must have been.
Well, I didn't go on strike. No, I don't remember that.
Yeah.
Was there one in 1975?
Yeah.
Oh, really? Well, little things I don't remember. But no, no, I don't. I think what has also changed is that when I was working my 120 hours a week, which I did for the first 5 years of my life as a doctor, except when I was on annual holiday, but the average time at work was 120 hours a week at work. The reality was, quite a lot of that time I was asleep. The hospitals were peaceful places. Our colleagues who are training in our hospitals now are run off their feet, and they are chaotic. Recently, I was in Holland because I'm vice chairman of the National Maternity Review at the moment. So we went to Holland, and I went into a hospital in Holland, and it felt like the hospitals that I worked in, 30, 40 years ago. It was calm. And they have an 80% bed occupancy.
Mm.
When I started to manage guys in 1985, when we had our little doctor's revolution, I said to the chief nurse, when I go back purely as a clinician in 3 years' time, how will you judge whether what we've been doing together, because there's a sort of group of us doing it, have been successful? She said, well, you could get the bed occupancy down. I said, well, what's the bed occupancy? She said, oh, it's over 100%. I said, over 100%? It can't be over 100%. I mean, in paediatric wards, you don't think about these sort of things. Oh, yes, it is, she said. Oh, I said, have you never heard of hot bedding?
Yeah.
I said, no. And so later on the day, I saw Professor McColl, who's Professor of Surgery. I said, Ian, have you ever heard of hot bedding? Oh, yes, he said. He said, I was going down around the ward the other day, and a man said, would you pass me my urine bottle, Professor McColl? He says, I got it. No, I said, no. He said, you don't need me to do that. He said, you go to the loo. He said, you're better, you can go to. He said, I'm not getting out of this bed, Professor. If I get out of this bed, somebody else will hop into it. Now, you cannot run a hospital at 100% bed occupancy.
I must just tell you, when I took over the chairmanship of a mental health trust, because it's common, mental health trusts, people go home on weekend leave, and you get an admission on a Friday or a Saturday or a Sunday, and when they come back on the Monday, you've got
Somebody
nowhere
else
to
has
put them. Exactly. I've had exactly the same thing. Coming from outside the NHS at that time, I was chairman of a health authority, but into operational management, I thought, how the hell does this, where do you put them?
It's ridiculous. In Holland, as I say, you know, it's very difficult to get into a hospital in Holland, and it's very easy to get out. Now, just contrast that.
Yes.
And
But we'll talk about that in a moment. Let's just go back to the junior doctors dispute. I mean, okay, so they're now, the nub of their dispute, and it's very difficult to characterise it because it is much more nuanced, but fundamentally they're concerned about the hours that they're going to have to work, which won't be guaranteed by the trusts, and the trust won't fall into sufficient penalties to be a disincentive to not to overwork them, and issues around the money that they will earn without their premium and overtime and antisocial hours payments and all the rest of it. It's fundamentally it's the same dispute as in 1975, which was hours and money. We're in the same. But don't you think that here we are now? The Secretary of State prays in aid his reasons for getting himself into this mess is that he's talking about the 24/7 NHS and all the rest of it. But to lump it all on the back of the junior doctors seems to me to be balmy. We're talking really about system change, not just hammering the junior doctors who are already there.
Yes, I agree with you absolutely entirely about that. But I would, I've said this to you privately, but in the Virginia Mason Hospital in Seattle, where they introduced the notion of patient safety alerts and real focus on trying to create a climate of zero harm, the chief executive, Gary Kaplan, who I've never met, but I've read a lot about it, at the same time as he was doing that, he introduced the notion of a compact, not a contract. He sat the doctors down and said, what can we do together to improve the care that we provide for our patients? And that is a professional relationship. It recognises the experience, the wisdom, the training, the responsibility of doctors. Doctors need to take responsibility for the delivery of care. It needs to be not just effective, it needs to be efficient. And they need to be given the authority to do that. And they need to accept accountability. That's what we did at Guy's in 1985. And that is a professional relationship. And they should be well paid, but they shouldn't be paid overtime, in my view. That comes with it. But equally, they need to have terms and conditions which allow them to have proper family lives and proper, and particularly nowadays when so many young doctors are married to other young doctors. And here we are in 2016, talking about saying, well, you won't have to work more than 72 hours a week. Well, I should hope not. 72 hours a week is an awful lot of time.
I think that's right. And a bit of me that says I don't want this dispute settled because it will be settled with the status quo with knobs on, won't it? We'll be just projecting the problems that we've got into the future. If this is going to be an opportunity to do anything, it's to change the whole basis on the way in which hospitals work.
Well, I'd like to see that, but then you've got to not only change the way hospitals work, you've got to change the way the health service works.
You changed a lot. Let's go back, let's talk about the time you were in Guy's when you took over there. I mean, you changed a lot there, didn't you?
Yes, we did. There was a big run-up to it. I mean, you can remember that the country went bankrupt in the late 70s and the International Monetary Fund came in.
Bailed us out, yeah.
And at that time, I was constantly, well, not constantly, but I was on television more than once, saying children are dying of renal failure in this country, and we know how to treat them, and the country won't provide the resource. Because the impact of cash limits meant there was no money for expansion, and the gap between what we could do and the money available was widening. And I felt at that time that my responsibility as a doctor was to the individual patient. Somebody else's job was to run the health service. But their job was to find the resource, my job was to spend it.
Yes.
And
the number of times I've written, it's the job of the manager to create the time and space for good people to do great things.
And that was my sort of view of the thing, and I was wrong. And so, and I didn't realise I was wrong until I went to the Johns Hopkins for a month in Baltimore, and they developed a system where they decentralised to clinical teams with proper management accounts, something the NHS doesn't understand. Is that it?
No, we're okay, I think.
Okay. And they decentralised it and given doctors responsibility for the efficiency, for the expenditure, as well as for providing the care and the treatment. And it occurred to me that actually it's an ethical responsibility for a doctor to have regard for the efficiency of the service that's being provided. Because profligacy in the care of the treatment of one patient is potentially denial of adequate care for another. So you've got to match your responsibility, your duty of care, the deontological ethics involved in doctoring, with a more utilitarian view that the manager or the politician has to have. And somehow you have to hold those two things, and it is possible to do it. Trust me, I used to be a doctor. It is possible to do it. But you've got to understand the need to do it before you can do it. And that was the debate at Guy's in 1984. And we had 3 meetings of the consultant staff, and we finally voted. And there was, and the vote went through. There were 7 abstentions, but the rest voted in favour. And so the deal we had was that we would deliver the 15% cut in expenditure, so more money was spent in the community, over a 3-year period, but in return for them giving us the responsibility, the authority, but being held to account.
Big chunk of money, though.
Well, yes, I mean, see, that's another thing. The first thing I did, I mean, first of all, they said I had to do it full time, and I said I wasn't going to do that, because that wasn't my life's ambition, to be a doctor. But eventually, the Secretary of State intervened and said, no, it had to be a doctor, it had to be me, but it had to be a doctor, and they agreed I could do it part-time. But one of the first things I did was actually to go back to the department and said, give me £1 million. And they said, you've been asked to save, the budget at times 50 million, I had to save 15% of it. So they said, you've got to save 7 million. So you're asking for £1 million. I said, you cannot do change unless you front load it. You've got to spend according to a strategy. You've got to put the new in before you can take the old out. I mean, I feel passionately that unless we completely reform primary care and keep people at home safely, then the hospital service is never going to work. But you will not do it in a piecemeal way. You've got to be prepared to spend on primary and community care. So anyhow, thanks to the wonderful Roy Griffiths, who was my mentor, I got the £1 million on the basis it would be paid back in 3 years' time. And we then made all the changes necessary in Guy's to accommodate the sort of, to increase its capacity, so we could eventually close New Cross Hospital, which was dangerous by then. And the consultants all took responsibility for their budgets, and the nurses, the senior nurses and the allied health professionals. I mean, I'm a huge fan of administration. Management, as Roy taught me, is a job. It is not a profession. Administration is a profession, and I didn't do this. I mean, my job was to provide leadership. It wasn't. I'm not very good at administration. But Nigel Smith, who was the chief administrator, was very good, and the two of us, and the chief nurse, and the finance director, and the clinical directors, one of whom was Harry Key, we did it together. And over that time, we did cut the cost by. We cut the first week. The big expenditure in a hospital is the number of people you employ. So I said, how many people do we employ? And they said, well, no idea about that. I said, what? They said, no, we don't know how many people we employ. So we had to find out how many people we employed. So the first month was spent trying to find out how many people we employed. And we actually found 3 people who we were still paying, who we hadn't employed for over years. I mean, it was so that's the sort of way. Well, anyhow, it happened, and it did actually work. We ended up, we cut the bed occupancy to around 90%. We saved 15%, and we ended up treating more patients. But you can only do that in an ordered system. But if you're in chaos, managing chaos is hugely expensive.
I mean, my next question was going to be, could you do that trick today? I'm not sure you could.
Well, it's easier. It would be easier to do it during the years of plenty than the years of famine. But actually, I think that's what's got to actually happen, Roy.
Well, I mean, we with the continuing austerity, we've had what 5 years in the period between 2010 and 2015. We've had effectively flatline funding, with demand increasing. They say 4%, but I rather suspect it could be more than that in some places. We've got another period of essentially the same sort of thing, although the money is stacked up slightly differently. But it's so we'll have had 10 years of flatline funding against 4% per annum growth. I mean, you get to the point, don't you? I mean, we've fallen down the European ladder of where the percentage of GDP. We used to be bang on the average, but now we're way behind. At the end of the day, money talks, isn't it? We've just got to, I think, to review how there's talk now, isn't there, about Stephen Dorrell, who we're interviewing, I think next in the series. He'll be talking to us. Stephen Dorrell and one or two others have got together and said we want a commission on the future of the health service. My worry with that is it will just kick the thing into the long grass. We know what we need to sort out with the health service, and not least of which is the interface between health and social care and the money thing. We don't need a commission to tell us what to do. Have a commission, it'll be kicked into the long grass. The politicians will love it, I think.
Money is a very difficult question. We're spending, it was 9.8% GDP, it's now 9.2%.
I think it's less than that, isn't it?
No, I looked it up the other day.
Is it?
You don't come to meet you without actually checking up the two things.
I thought it was less, but anyway, we'll go with your numbers.
Anyhow, where you're looking at different figures, but you're quite right, it's now dipped below European average. However, it's not out of the sync of Japan or Norway. And remember that Hong Kong seems to do very well on 5.6%. And so...
acupuncture.
Whatever, I wouldn't know. But I don't know why they do so well, and I've spent quite a lot of time there over the years because I used to advise the hospital authority. But if you put more money in now, without a sensible plan as how to spend it, we'd be back here, well I won't be, but somebody will be sitting here with you in a few years' time saying, well, what went wrong?
Well, look, we've got the 5-year forward view, okay?
Yeah, well,
do you understand the 5-year forward view?
Well, I do. Well, I don't understand, but I mean, I do think that many of the things in it are absolutely right. They're trying to find new ways of providing services.
Is it deliverable?
Particularly in the, well, yes, but over what sort of period?
What, 5 years?
And that's, well, yes, but in fact, it's like that Andrew Marvell poem, at my back I always hear time's winged chariot hurrying near. I mean, it's a question of pace and scale. Now,
Have you looked at the vanguards?
Sorry?
Have you looked at the vanguards?
I know about them. I can't say I've looked at them.
Yeah.
But I do chair a practice in outer northeast London, which is for people with 5 or more chronic conditions, which is designed, it's only just as part of the Vanguard process, it's the Prime Minister's Challenge Fund. And it's a practice built very much around the Wagner chronic disease model, which I strongly favour, which involves getting specialists to work alongside the generalists, particularly geriatrician. I mean, can I take you back a bit to 1963?
1963?
Yeah.
Yeah.
1963.
Good year. The
well,
Beatles were #1 in the hit parade.
And I qualified that year.
Really?
Yes. And
I was running a business.
And the expectation of life for a man in 1963 was 68 years. It's now 78, 79 years.
I must say, shall I tell? I made a film just recently with Bruce Keogh about numbers. It's called Fabulous Fat Friday, thing we're doing with him. And he said to me that the average lifespan of a man is 78.6 years, you see. So I said to him, that means I've got 8.6 years to keep annoying the NHS. And then he turned and said, if you're lucky. and I completely cracked up and we had to start the film all over again.
Well, in
1963,
the Minister of Health was Enoch Powell. Now,
The Shadow of the Water Tower. Do you remember that?
No.
He wrote The Shadow of the Water Tower. He talked about mental health trusts and people living in the shadow of the water tower. A definitive piece, and he first described really community care for people with mental health problems. Good.
He was a very good minister.
He was a clever man. I mean, you only remember him because of the Rivers of Blood thing. And that has to be part and seen in the context of the day. But actually, he was a very good health minister, I thought.
And in 1966, he wrote a monograph called A New Look at Modern Medicine. I think it's a new look at a new look at medicine and health. Anyhow, you can get it off the internet. It's on the Social Market Foundation. Just put Enoch Powell in 1966, and it's there. And it's a fantastic read. It takes about 2 hours to read. It's about 80 to 100 pages long. And it's like Joe Simpson's Touching the Void. Once you start it, you can't put it down. I mean, and it's very, very funny. And it's finally very depressing. Because what he says is that the NHS will never be effective because it's fundamentally unsuitable to be run by a political minister. But the clear fact is, where taxpayers' money is at stake, a minister accountable to Parliament has to be responsible. And I spent much of my time when I was on the NHS Policy Board and trying to work out how do you find a way of getting the decentralisation which is necessary with the central financial accountability. I mean, actually, Anara Bevan said the NHS is an experiment between centralised financing and decentralised administration, two things which are normally kept very closely.
Yeah, I mean, I think he said a lot of things that were in the spirit of compromise, weren't they? Because he was struggling to get people on board. I mean, I'm not sure that, I mean, I'm not in any way saying it wasn't a noble and fantastic thing that he did, but I think a lot of what he said at the time was playing two ends against the middle.
Pretty well, and also the fact that, GPs are fundamentally in the private sector, which the British people don't sort of understand.
And he tried very hard for them not to be.
Yeah. And of course, Herbert Morrison wanted it more in the LCC. That's coming back with health and wellbeing laws. Anyhow, back to Enoch Powell. He introduced district general hospitals, and that was on the basis that you needed hospitals need to serve larger populations in order to have the specialities and the technology to make them effective and efficient. And I can remember when I was a houseman in East London, a paediatric registrar, not a paediatric houseman, a registrar. When I was a paediatric registrar at the Queen Elizabeth Hospital in Hackney, when I was on at night time, I was on call for the Queen Elizabeth Hospital, the Metropolitan Hospital, the German Hospital, Bethnal Green Hospital, Hackney Hospital, and the Mothers Hospital, Salvation Army Hospital up the Clapton Road. They've all closed because they were serving small populations. And a man called Peter Draper, I think that's his name, yes, and he was a GP, and he was, I think he's still alive, worked in the social medicine unit at Guy's Medical School, and he wrote a paper in the Lancet, 1967, which is worth reading. And he said, if you're going to close all these little hospitals, you've got to remember that's where the general practitioner and the specialists come together. They also provide the sort of kits, such as it was, like path testing, x-rays, to the local populations. If you're going to close them, and I understand you need to think about how you're going to connect primary care to specialist care. And he suggested community hospitals, not necessarily with beds, ambulatory hospitals, serving populations of about 50,000 people, sort of thing we're talking about with federations of GPs and community hubs at the moment. That's 1967.
We go around in circles, we go
really
back.
important, because now the district general hospitals are closed, and so the hospitals are serving much bigger populations.
Do you see closures of more hospitals now?
Well, I wouldn't close any hospital if I was Minister of Health, and what I would do is look at how they function, and they need to function as part of networks, it seems to me. I mean, I'm sorry to go back to Holland, but the Dutch 10 years ago reorganised the health service. They said, right, one part of it's about looking after people with chronic illness, one part of it is actually the sort of stuff we regard as the health service, which is hospitals and GPs and ordinary day-to-day care, and then one part is about therapists, dentists and physiotherapists and so forth. Now, the chronic disease management bit is 75% of the health service. I mean, you can have all the markets you like if you want to on elective care, but in chronic disease management, you need integrated care. And increasingly, it has to be integrated between health and social care, and it is to be locally coherent. And as part of the maternity review, Baroness Cumberland and I went off to Holland, and we went to see birdsong. Does anybody know about birdsong?
Oh, we're big fans of birdsong.
Birdsong
My
is-
readers will know I write
Have
always.
you,
about
have you
birdsong.
met Josta Blom?
Yes, I have. Yes,
He's a
yeah.
star.
Yes.
We went out with birdsong nurses, and his notion, for those of you who don't know, is that neighbourhoods need to have teams of district nurses, no more than 6. If you get more than 6, then you need to break like an amoeba into another team. And
Let me get rid of that.
And so we went out with this nurse, and she was absolutely wonderful. And we saw 5 patients in about 3 hours, and she knew all of them, and the sort of organisation of care. And we saw one lady who was 75. She lived with her son, who had been in and out of prison. Her other children had left. She had had a stroke. She was in heart failure. She had diabetes. She had a catheter. And she was visited twice a day by the district nurse. She hadn't been in hospital in 3.5 years. And the love that was involved in the care was just astonishing. But she needed her prescription changing, so onto the little tablet, straight into the internet, because you get internet access through wireless in everybody's homes in Holland. So zoomed off to the GP, back saying the GP I'll call in at 5 o'clock today. And it just is highly efficient. He's cut costs by not having lots of people wandering into the home, but by 30%, and that's irrespective of the costs he's saved by people not going to hospital. That's why they run 80% bed occupancy. It's very well organised community care. And we went to see him in his office, and Julia Cumberland said, "So you're the chief executive?" He said, "Yes." And so she said, "And who's your chairman?" Oh, he said, "Well, I'm the chair." And so I said, "Oh, all right." I said, HR? Oh, yeah, I'll do that. He said. Finance? Oh, I said, "I'm the finance director." Complaints? Of course I do complaints. I said, "But you're employed." By the way, he started in 2007 with 4 colleagues. There are now 10,000 birdsong nurses looking after 70,000 patients across Holland in this way. So I said, "Well, payroll. You've got a big payroll." He said, "Oh, well, the wife does that." It is astonishing, but it's that sort of organisation.
Step change, absolutely. We're big fans of birdsong. Let's take you back to your time when you were doing things at the centre with the department and the rest of it. Of the ministers you've worked with, who do you think understood the NHS the best? Because they sort of come in and they do their bit as politicians, don't they?
It is terribly difficult for them because, I felt for a long time the problem with the NHS is it's accountable upwards, whereas in fact it needs to be organised downwards. It needs to start at the level of the patient. It's like the information technology. Oh, dear. But I mean,
We haven't got time because it's 6:45 and you've got
okay,
to go.
yes.
So.
But again, it's always organised about how does the administration use the information technology. It ought to be organised is how do the patients, the care get organised through technology like birdsong, and then the administration is
But
put
we've
on
got
top
the
of it.
National Information Panel or whatever it is with 68 members on it.
Is that right?
That's Tim Kelsey's. Well, Tim's going now, but yes, the National Information Board's got 68
Well, I used to be on the
members.
care.data board, but
Well, you made a mess of that, didn't
well,
you?
I resigned.
What
It
the
didn't seem to help them.
What the hell happened with that?
I've now gone back on it because Harrison was charged. But you see, that was, to my mind, fundamentally about asking patients for their permission. I was chairman.
But the legislation didn't encompass that. In the Health and Social Care Act, it did not say that we had to ask. It just said that the data will be extracted.
But that's what the law says. I was chairman of the Standards Committee of the General Medical Council. In 1999, we produced a new version of communication or confidentiality. And somebody stood up and said, "You realise the advice you're giving is unlawful?" I said, "No." And they said, "Well, it is." The Community Health Council had been to see a QC. So we got a QC to look at it, and he said, "It is unlawful under the European Human Rights Act." And that's why the Patient Information Advisory Committee was set up, to try and legitimise the unlawful until such time as the situation could be improved. the reality is that the law is quite clear. If you're using personal data, you've got to ask the patient. But if you ask the patient and tell them what you want to use it for, in my experience, they say, of course. Why would we not
I
want
find they're surprised that you don't. You know, they're,
Exactly.
yeah. Oh, come on, you've ducked the question on the ministers that you work with. Who do you think understood the NHS the best?
Well, let me just say, I do think it's jolly difficult because, in fact, they're not there very long and it's very complicated. And if many of the people in this room, including me, don't completely understand it, you can hardly blame them. But having said that, I thought Ken Clark was super. I can remember he was given to the occasional soliloquy in health NHS policy board meetings, and hope he's not watching. Anyhow,
I can.
but he once said, you know, everybody's criticising me because they say that I'm only interested in winning votes. He said, but actually, he said, I'm losing votes all the time now. He said, because I've been told, and I actually agree, that we need to close these huge mental health institutions. He said, it's costing a fortune. And many of my voters don't think it's a good idea anyhow. He said, but I'm doing it because it's the right thing. And it seems to me that many politicians do want to do the right thing. And, but it is very difficult when you've got a top-down system. There's something called the European Health Consumer Index, which you probably know about. It's an annual review of health services. It's very much based on outcomes. It's rather like the Commonwealth Review, but not weighted in quite the same way. But the man who runs it every year has a chapter heading that says, once more Bismarck has outperformed Beveridge. And his position is that if you keep the politicians away from the operational management, you get a more patient-friendly healthcare system. Not necessarily a more efficient system, because NHS funding is a very efficient way of doing it.
The system, I think, is probably good. It's what we do with it afterwards.
Well, I think the Scandinavians, of course, they fund their system partly from local taxation. And, you know, I don't think you were very keen on the 2012 Act, were you,
No.
as I recall?
No, I had one or two reservations.
Yes, I noticed. but there was what I humbly submit to you. There was one thing which has worked out, again, wonderful serendipity. The Liberal Democrats wanted to make primary care trusts democratically accountable. They wanted elections. But that wasn't, as I understand it, in the coalition agreement in 2010. So what was agreed upon was that the local councils, who of course are democratically accountable, should come together with health in provision of community services through health and wellbeing boards. And of course there's been significant transfer of revenue now to those.
What have they achieved?
Well, it's not what they have achieved, it's what they have the potential to achieve.
Well, they had 4 years together, actually.
These things take a long time.
It's a lot of money as well.
I know it is, but just look, the vanguards are moving down there. There's an accountable care organisation in outer North East London, which we are sort of associated
the District Health Authority when I ran one.
Yes, yes, but it didn't involve social service.
Do you think it should?
Oh yes.
Would you merge social services with health?
Yes.
Well, be
at a
careful,
local level.
be careful what you ask for, because social services is means tested. Does that mean health will be means tested?
I think.
Come on, let's have an answer.
I think they have to produce packages which are of
Means
care,
tested?
which are health and social care. Some of it would have to be means tested.
Which bits?
Well, the social care bit. But before, but before
Are you talking about a health bath or a
before
social
I
care
go,
bath?
before I go into the detail,
You're not.
What
You've
I-
got 10 minutes
Yeah,
left. Yeah. Forget the detail.
no, I can't forget. I never forget. What I
I want to talk to you
what
about
I
maternity
what I all right. What I want to suggest to you is that Roy Griffiths did 2 reports. He's the one everybody knows about, but he did another report, and because Mrs. Thatcher wasn't very keen on councils continuing to provide social service, and when he did it, he went to her and said, that she said, Mr. Griffiths, I've read your report and I don't like it, but you can explain it to me and I'll listen. And he said she listened without interruption, 25 minutes. And when it was, he's written about this, but he told me about it, she said, still don't like your report, Mr. Griffiths, but you're right. And that's why social services stayed with local councils, but they did move into a commissioning role. Now, a lot of the support for people has to be socially organised. You know this from mental health. I mean, there are people in our communities with packages up to $250,000. I heard of one today, 400,000 a year for support in the local community. And some element of that does have to be.
They're the exception, and
yes,
it's a bit like specialised commissioning. But if you get the average, elderly frail person, acuity going down, Charleston scores
what
very
you
poor.
need, what I think you need, is to be kept at home, wherever you can, not in residential homes unless you have to go there, or in nurses' home. It's the Burt-Sod model, keep you at home.
I agree with the
Now,
Burt-Sod.
if some part of that you have to make a contribution to, because you can afford to do it, then I think you should.
Well, if you can't, then that's a rich person's charter. I mean, come on, you either pay for it or you don't.
But if you can't afford to do it, the state should provide. And
so it will be means tested.
Of course, that's what I said. I said I don't disagree with you. But you said which part of it, and I said the social care part of it. And I'm sure you and I could sit down and work out how to do that. But not in the next 10 minutes. What do you want to ask me about maternity?
Well, you're doing it very easy. Wriggling off there. I'm interested in the review you're doing on maternity with Julia Cumberledge, who gave me one of my first jobs in the health service. Wonderful woman, great judgment, spotter of talent. But why don't we? Yes,
she's very proud.
Why? I said to her the other day, "Oh, hello, boss." She said, "Who are you?"
No, she knows who you are, because I told her I was coming to do it.
Oh, really? Why have we got another maternity review?
Well, you'd have to ask Simon Stevens that, because he commissioned it, and I don't know the answer. What I do know is that there was a report from
a certain hospital got itself into a mess, and there was you could argue there was a disproportionate press response.
I think Morecambe Bay was part of that.
Yeah.
Probably we might even get onto regulation before 7 o'clock.
Yeah.
Given we share a common interest. But as far as maternity is concerned, it is the case that it is twice as safe to have a baby in Sweden than it is in England. And
having a baby or the
having a baby.
The survival of the child after birth. I mean, is it death at birth?
Well, it's the perinatal mortality rate.
Yeah.
But which is better. But there are hospitals in this country as good as anywhere in the world. North Bristol, for example, fantastic. And so the question is, if the Swedes can do it. Incidentally, in Sweden, they don't have a general medical council. They don't have a...
Rather hoping we'll get rid of ours.
They don't have a CQC. They don't have any Royal College.
How do they manage without the CQC?
And they don't have any Royal College. Anyway, that's by the by. But the service is funded locally by the Stockholm County Council. They have that mixture of local accountability as well as national. But that's not why they have better outcomes from pregnancy. They have better outcomes because they have really very, very good teamwork. And one of the things that my generation has failed, and we have, is to understand that we've moved since 1963, when I qualified, to today, with a model of healthcare which has been wonderfully successful. I mean, the fact is that when I talk to a room full of people of my age, I can be sure that half the people in that room would not be there with the knowledge of medicine when I qualified. I mean, it has been a wonderful success, and we shouldn't forget the National Health Service has made a major contribution to it, and we complain about it, it's got problems, but it's still a very good service. But put that to one side. What we fail to understand is the model of medicine where it was one individual who provided care with a group of people helping her or him do it, has changed to a team of people. When I was appointed to Guy's, there was me as a paediatric nephrologist and general paediatrician. When I retired, there were 7 of us. Now, continuity of care is crucially important. And we've forgotten that we needed to change the way we work, the way we communicate. You cannot do continuity of care in maternity or chronic disease management or end-of-life care without four things. You need a care plan, you need a key worker to advise you, you need a multidisciplinary workforce like Buurtzorg nurses, and you need an electronic record. And that is key to the continuity. You need proper handover, and you need training together as a team.
So is the bottom line on maternity better trained midwives?
I can't actually at the moment tell you what the bottom line on
More
maternity
midwives?
is.
Because
And I can't even tell you that. But what I can tell you, generally speaking, Mr. Lilley, is that
give us a hint.
that if people work together, they need to train together, and that has been the experience.
Yeah, but you're
in
not going to make a
Stockholm.
whole load of recommendations that are going to get kicked into the long grass about
No.
training and blah blah blah.
No,
I mean, how do we make it? How do we
In
make?
2008,
How do
there
we
was a-
make it safe and next year?
In 2000, well, you know that I think on February, whenever it comes out, which might have been.
No,
in
it's not
February.
going to be.
But,
one that's
but in
complicated with
2000,
bad things.
2000, we won't have 200 recommendations.
Oh, really? Robert Francis will be very disappointed. Yeah.
We won't have 200 recommendations. But
How many?
I don't know. Well, I do, but I'm not going to tell you. But
10 or more.
But I'm not going to tell you that either. But I will tell you, if I can remember what I was actually going to say, is that if you don't, in 2008 there was a report from the King's Fund on maternity services, a very good report. But the fact in 2015 they needed to commission another report tells you that what the 2008 report didn't make much difference. It was a very good report.
Well, none of these reports.
Well, my hope is that our report, and it's a group of people who are very much involved, President Royal College of Obstetricians, midwives and so forth, will actually make a difference, and the recommendations will be practical, and they will be in a form where you can check as time goes forward whether we've made progress.
That's if they're accepted by ministers. Isn't it just the case that we've been caught out on planning? There are a lot more births than we thought, and we don't have enough midwives. Isn't that the bottom line? Isn't that not right?
That's not right.
What is right then?
What's right is that the services we're provided are not coherent in the way that they are in Stockholm and they are in North Bristol.
So have we got enough midwives?
We've got enough midwives. Whether we're employing enough midwives is another
So
question.
one of the recommendations will be to
And
employ more
we need to get
What are the other
people
nine?
back. No, I haven't said no. You're going to have to wait.
Well, I'm sure it'll be worth it. Look, we've got a few minutes left. Let's talk about the regulation in healthcare. And my gosh, what a difference it's made in the last 16 years that we've been bussing people around the country, making charabanc companies and hotels rich, while inspectors walk around hospitals and saying, I've seen an empty drinking glass out of the reach of a patient. Discuss.
Well,
We should close the CQC, shouldn't we?
I debated at King's in April, and the motion was, has professionalism and trust in the NHS been destroyed by regulation? And my view is that what makes most doctors, nurses and allied health professionals go into the job in the first place is what's used to be called a vocation. They want to do it, and they want to help their fellow human beings, and they work for love as well as for money. And the danger with too much regulations, and every game has rules, and the rules have to be observed, so I'm not opposed to regulation in that sense. But if it gets overweening, it destroys trust. And trust is, and being trustworthy is fundamental. So we need rather more professionalism, and we need a service which recognises professionalism, respects it, and rather less regulation. So I don't think there's a simple
How much
answer.
less?
Well, quite a bit less actually, Roy. I want professionalism, but you can't do it unless you do what I suggested earlier on, which is tear up the contracts and start again with compacts. And you also, at the same time, have to have a service which is more manageable. managing chaos is very expensive. I chaired the SARS inquiry with Sean Griffiths in Hong Kong, and the Hong Kong people did a wonderful job during SARS, but there was one moment where they had a secondary epidemic, and patients, a large number of patients were sent into a hospital, and the hospital was overwhelmed, and so for the first time they got secondary infection across the hospital because their systems had broken down. When I was in Holland, I said to the chief midwife of the hospital, so how much cross-infection do you have? She said, we don't have any. I said, none. I said, MRSA, she said, we don't have anything. I said, methods, and she said, we know what it means. She said, we don't have any. She said, if there's any cross-infection in our hospital, an email goes round to all the members of the staff, and I can't remember when we last had one. I was in arguably the best hospital in the whole of the universe, which happens to be near London Bridge.
Friendly Park.
Recently.
Friendly Park in
Recently. And I went to see a friend of mine who was in the ward, and the notice said, the last case of Clostridium difficile, and it was about sort of a few weeks earlier. But in Holland, everybody has their own room. When one customer leaves, as used to happen in the old days at Guy's, the mattress was taken somewhere else and fumigated, and the bedstead was washed, and the area was cleaned. But 100% bed occupancy.
You can't do that. So what about the GMC? I mean, they've kind of got bigger and fatter, haven't they? Living in their two enormous glass offices. God knows what their operating costs are.
They're a lot smaller than when I was on it. There used to be 100 members of it, and they're down to about 10.
I think, have you seen Neil Dixon's offices? There's like a Pendram person.
Yeah, they're very nice offices. Yeah.
Shouldn't they just keep the register and let the employers get on with the rest?
No. Have you read Good Medical Practice?
No.
Well, I think Good Medical Practice.
Oh, it's the report, the last report.
No, it is. It ought to be. Well, it is the ethical standards that doctors are meant to meet.
Sorry, yes.
It's very well written.
I'm familiar with it. Yes, but I haven't read it. But I've had to write about it. So. Anyway, go on.
Well, it actually describes something way above the minimum legal standard, and that's the trouble with regulation, because regulation
it takes
has
15
rules and
months
laws.
to sort doctors out. You have to pay
Oh
for
no, I agree.
leave and
You're quite right about that. It takes far too long, and it causes huge fear. When I was on the GMC, I used to get 3 letters a week from them, about standards matters. But every time the letter dropped through the letterbox, I picked it up and said, GMC, your heart misses a beat. You think, oh dear, what's this? And I don't think people quite understand how doctors feel about that, because it is, your whole career can be stopped or put into turmoil for 2, 3 or 4 years, and that's much too long. Justice delayed is justice which is not adequate. But having said that, I think the standards are absolutely very...
Well, but they are, but it's how they do it. I mean, Neil, I spoke to him, and Neil is coming to do a health chat evening with us, so it'll be quite interesting. But what is it, John?
June.
In June. And I remember talking to him, and he says, I mean, he will speak for himself, but the problems he's got with lawyers, and he can't do anything quicker than 15 months. Well, come on, as you very rightly say, it's people's careers. It's very disruptive for the doctors, and of course the patients involved are just hanging on. It looks like we don't care because it takes so long to investigate all these things. I just don't know why we just don't dump the whole thing. Just have the GMC keep the register. Somebody has to, and the rest is down to the employers. I mean, if you run a business, you don't have external people telling you who you can employ, who you can't. If you want to make sure that they're properly qualified, and if they don't do a good job, there's the door. If there's a disciplinary procedure, you can deal with it straight away. If there's a problem, there's a tribunal, and that's it. You don't have all this palaver. Do you?
As I say, there are countries that manage successfully without it, I have to admit that. But I do think good medical practice as a bulwark for professionalism is worth having. And if I had I have no authority of any sort of talk, so I'm retired. But if I had one wish, it would be that we can re-professionalise the delivery of healthcare, and then, and I think it's possible to do it, and I think at that point some of the other problems, which are secondary problems, like the current dispute with the young doctors, would actually not arise.
I know we're over our time now. I'm very happy if anyone would like to ask anything, just put your hand up and let us know. Terry, have we got anything on Periscope or Twitter yet?
No particular questions. Ruth Carnell sends her love. Passing that on.
This is not the...
I'm sorry.
It's not his fan page. Her love to me?
No. No,
To
not
Cyril or me?
To Cyril.
Could you just clarify?
No, she's very specific. Not you.
Really?
Can you send mine back to her?
Could you tell her I'm sulking? Yeah, of course, yes, far away.
I mean, just this very point that you're on at the moment, actually the two of you are sitting at opposite ends of the debate, where Cyril, quite rightly in my view, looking at increasing the emphasis on professionalism, but you can't put the responsibility back with the employers then, because the very difference between being professional and being employed is whether you are driven by the requirements of the profession or driven solely by the requirements of the employers.
I think you need both. I have a slide when I talk about these things, and I have visual aids.
Do you still use PowerPoint?
No, I don't.
For God's sake. Can you work it?
Yes, I can, but no, I don't use it very often. But my slide just has two words on it. One is conscience, and the other is contract. But the conscience comes first. And at the moment, the contract is all. The conscience is not recognised at all. And I think that's why we're
You
in
can
trouble.
belong to a profession and not be very professional.
But Roy's point about the employer being accountable for someone's conduct entirely is fine from the employment contract point of view, but it doesn't address the conscience and the integrity of the profession.
Well,
as a
I
whole.
mean, I often get asked that question. My answer to that is, well, I just give them the sack, and then if they go and try and get a job somewhere else, they'll have to come to me for an opinion, and I'll say I gave them the sack.
But Roy, you know, most of healthcare goes on without the employer knowing anything about it. And the whole thing about professional bureaucracies, as Mintzberg pointed out years ago, is the people delivering the care know what to do but aren't very sure what they're meant to be doing, and the people at the centre who think they're running the organisation have a good idea of what they're meant to be doing but don't know how to do it.
That's a very nutty answer.
And how do you bring those two things together? And conscience is, you know, what goes on
Well, that's to say
in the
that
privacy of healthcare.
Employees,
Yeah, but-
employers can have conscience
Yeah,
as
but
well.
the consequences
I'm
of
conscious
getting
of your
that
time.
wrong
I'm
are
gonna-
pretty awful for patients.
Well, that-
so you need both.
But you start with the patient and work backwards.
You do.
Right. Listen, we've got to...
So you start with conscience.
We've got to
and work
finish up.
backwards.
Final word of advice for Jeremy Hunt?
I think if I were him, I'd send for Roy Lilley.
Very, very bad. Very bad. The end of Roy Lilley's career. You've been a fabulous guest. Thank you very much. Before you go, we always have a little gift for our guests. John has got it there. It's a bottle of Welsh whiskey,
Oh, how
which
very nice.
we irritate all the Scots by saying it's the best whiskey in
Thank
the
you.
world. And this won't apply to you, but it's an expensive bottle of whiskey, and it's just above the limit where ministers and others and employees of the NHS have to declare it. So our name must have gone on the register.
Well, this is
But
lovely.
you don't have to bother.
And given the new guidelines, it'll take me 5 years to drink it.
Don't start me off. Do not start me off with Mary Poppins. Sal's my gal. Yeah.
Thank you very much.
Thank you very much. Wonderful. Okay, if you're on Periscope, I hope you enjoyed that. It'll be up for about an hour, and then that's it, I think.
24 hours.
24 hours. 24 hours.
We will be
recommend-
putting it on YouTube.
Are we going to do that on YouTube? We're still trying to figure out how to do it, but somebody will
We're
know.
going to sort it out.
And we'll see you next time. Thank you for joining us.
Could I just say we've got more drinks out there. Do hang around. It's a good networking opportunity. You can speak to Roy, speak to me, speak to the blonde here. If anybody wants to know more about the Academy of Fabulous NHS stuff, come and talk to us. If anybody needs to know anything about IMS,